Thank you. Welcome everybody to the uh, September 24th Joint Conference Committee for Zuckerberg San Francisco General Hospital today. And our Executive Secretary will call the roll.
Sure, I'll start with you, Commissioner Chow.
Present.
Commissioner Green?
Present.
And Commissioner Christian?
Present.
All right, thank you. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the August 27, 2024 meeting minutes.
So the minutes are before you. A motion for acceptance is in order.
So moved. Second.
And there is no public comment.
Okay, so let's call for the vote.
Oh, yes, of course. Commissioner Chow.
Yes.
Commissioner Christian.
Yes.
And Commissioner Green.
Yes.
All right, thank you so much. The minutes are approved. We can move on to item 3, the regulatory affairs report.
Good afternoon, Commissioners. Emma Moore, Director of Regulatory Affairs, here to provide the regulatory report for September. So you can see there that we have still a number of pending surveys because that is perpetual. I can share, I think from a prioritization standpoint, the 4A revisit is the top priority. Yesterday we had a revisit related simply to the fire life safety portion of the visit, which went extremely well. But we are hopeful that the state does elect to come in the very near future, possibly tomorrow, before the census in 4A drops to the point they might not be able to do the survey. The condition level findings are related specifically to the kitchen, and CDPH has been up until now unable to give us any tangible, yes, they would still come because the kitchen will still be fully operational to be able to clear these findings. So we're kind of in a waiting game. The other survey I'd like to highlight is the CARF OTOP accreditation survey. So in Ward 93, 95, next week, Wednesday through Friday, there'll be 2 surveyors surveying the methadone clinic. That is their triennial, like kind of their equivalent or joint commission. It's just in a different accrediting body. In terms of survey activity that happened in the month of August, we had the CDPH CMS complaint validation revisit for inpatient psychiatry, where they were able to clear all the condition level findings and no additional findings were identified. Then we had the California State Board of Pharmacy sterile compounding relicensing survey, which overall went well. And to provide an acronym that should have been in there, ADDS stands for Automated Drug Delivery System. I keep forgetting it, so I had to write it down. And if you're familiar, that's like an Omnicell or a Pyxis. It's essentially the machine that the nurses go to get the medication. So we just needed to provide a self-assessment, which was completed to the Board of Pharmacy, is what that finding was about. And lastly, we had the Department of Healthcare Services OBOT OTOP survey, so their annual reassessment, and there was only one finding related to documentation of patient tattoos from a kind of H&P standpoint. That was a recommendation they made. In terms of plans of correction submitted, I had mentioned that we're waiting for that 4A revisit, so we did submit the plan of correction for those findings. Overall, the kind of state of this survey is that there were 5 clinical findings, none of which were significant or widespread in nature. There were 3 kitchen-related findings. So general cleanliness, specifically underneath the cooking equipment, hand hygiene during tray line, as well as the ice machine maintenance. And the surveyor elected to group those 3 findings into one and then call it a condition level finding. Every kind of expert we've talked to in the field has been surprised by that decision, but we are ready for a revisit. And we've been, from a preparation standpoint, we have been doing repeated mock surveys, if you will. So we actually had a real environmental health and safety surveyor who happened to be out a few weeks ago. And then additionally, the regulatory team has done a mock survey. And yesterday, we got the Director of Infection Control for the Health Network, Jackie Francis, to come in as kind of, she's unfamiliar directly to some of the supervisors there. And so she acted as surveyor. And overall, we are cautiously optimistic, because I never like to be confident until it's done, that will go very smoothly. Additionally, on July 22nd, we had that life safety code survey. We submitted the plan of correction for that. And yesterday, we had a surveyor from CMS who had flown in from Chicago, a deputy director who was doing a validation of CDPH's surveys, came out, looked at all of our compliance work, and was satisfied with that. So that went well. And then lastly, as I had mentioned, the Board of Pharmacy ADDS self-assessment was the final activity that happened from a plan of correction standpoint in August. Moving to the CDPH facility reported events, year-to-date total, we are currently at 30. I think I maybe got ahead of myself in June when the numbers were looking like we were coming out because the last couple of months we've had 7 events reported each month. You can see there, I would attribute that increase to privacy breaches as well as COVID outbreaks. I think there's been 4 or 5 of COVID outbreaks this summer, and there's also been a number of privacy breaches. So for the month of August, 2 privacy breaches, 1 COVID outbreak, 1 HAPI, 1 facility incident, which was a planned outage that we notified CDPH of, and 1 alleged sexual assault. So we are continuing to track those. Moving to plan of correction monitoring data, I am happy to give more feedback with the small print. I apologize in advance for that. But as of 8/31, 71 of the 82 findings from Joint Commission have been fully addressed. Their monitoring has been fully addressed, and then we are working towards that for the inpatient psychiatry complaint validation as well. In terms of the complaint data, you can see there that, you can see our kind of running total, as well as for the facility reported incidences on page 4, that there's a total of 50 reported fries. And I think there had been a question about kind of was this typical given the number of kind of open lagging complaints, and I would say unfortunately yes, absolutely. I believe that Laguna Honda's data would in this sense would probably look much prettier because the state has been much more aggressive about actively investigating out and closing their cases given the amount of time they've had surveyors present. We still have cases where they are from 2020, 2021, that they are still kind of randomly resurfacing or not resurfacing and then just sending us a plan of correction for. So it is an ongoing challenge. Last week I can share we had a kind of Bay Area regulatory professionals group meeting, and this was very much shared as a consistency that I think staffing potentially is of concern in some of the district offices, and so that is leading to delays. So we will continue to track this, but I think that is the factor. It is very much beyond our control, and so we will continue to report all facility reported incidents that are identified, and as the state comes back with questions about them or as they come out with complaints, we will certainly continue to address them. And with that, I will open it up for questions.
So is there any public comment?
No, there's no public comment.
Okay, so commissioners, questions. I'll start with Commissioner Christian.
Thank you, Dr. Chow. Thank you for the presentation. And my first question is where you left off about the number of open complaints going from 2022, 2023, even maybe even earlier. So am I understanding correctly that the state is explaining that based on their lack of staffing?
My only explanation that I can say that I've heard from the state was last winter with the California Hospital Association that they invited CDPH to a webinar where they did kind of, I think since COVID, they've been retooling. My understanding is they are very much focused on skilled nursing facilities and less so on general acute care hospitals. From our district office, I have not heard any formal explanation, but I would say that any data in that section from an outstanding investigations is entirely on their side of the fence, not on ZSFG's.
And I certainly believe that you are doing whatever you think is appropriate to check in about those outstanding decisions.
Yes, yes.
Yeah, that must be very frustrating.
You kind of just
roll with it.
Yes, it's waves. You just accept it, and
yeah.
Whatever the day brings, you take.
You seem to be very practiced at that. I admire it. My other question is on page 2 of 5, talking about privacy breaches. Can you speak generally about what that category often includes?
Sure. So we have the Office of Compliance and Privacy Administration for all, I think, of DPH. We have a privacy officer at ZSFG, and they make the determinations about any of the privacy breaches. We, regulatory from a data standpoint, we actually report to CDPH, so we're sort of the processors and information keepers, if you will. But I can give you a couple of, giving them general, given that we're in open
Yes.
session, but I have them here. So one example would be an inadvertent list of PHI that was sent by an HR employee to a union representative. And the second one that was reported here involved a employee who elected to break the glass on a high-profile case. So that would potentially be considered as snooping. So I think those for the two that are referenced, yes, the two that are referenced here, that would be the two instances.
When you say break the glass, you
So they have the ability to put on, the privacy office has the ability to put on a kind of lock, if you will, into Epic. This would also be true for like any mental health patient, for specifically for those records and other such restricted patients. But for any time that it's a high profile individual where there's a higher likelihood that someone might go snooping, we put that feature on so as to kind of give people a chance to think twice about whether they really want to click into that chart. And in this instance, someone did.
Okay, thank you. So generally, these are data breaches, not person-to-person kind of.
Almost exclusively. I would say I think in 10-year quality career, I'm aware of maybe an instance or two of kind of inadvertent disclosure of status or something in like a double patient room. Like things like that can happen, but it's almost exclusively either going into the electronic record or losing pieces of paper.
Very helpful, thank you.
Commissioner Green?
Well, no, you answered the two questions I have. One was what ADDS was, and
I
the
had to
other
Google.
was whether the diminished census at 4A would create barriers to completing that revisit. And you answered them, so thank you so much.
Thank you.
So I just wanted to follow up on the privacy breaches. Is it that these are isolated examples, or is there a trend? As we look at the nation as a whole, we seem to be having more and more and more privacy breaches reported, right? And I think personally, in each of our mail, every so many months, we get another notice that there's been a privacy breach, and I don't know how many times they've told us that we could, have access to the scoring companies, right? Like that take care of us. So, how do you feel? Because now we're at 9 already, and there was only 11 last year, and we're kind of halfway through the year.
Yeah, no, thank you for the question. I think I would say that formally, I would probably defer the answer to the Office of Compliance Privacy Administration, but to give you my 2 cents from having very much kind of been involved in it, I would agree that there's been an uptick. I think we had a meeting just last week about one group in particular where they work at doing front desk registration, and so they're having to kind of creatively try to find records. And I would say from my perspective working in quality, I think one of the things is that, with this doesn't attribute necessarily a direct recent piece, but kind of the longer standing, the accessibility of medical records that, even 5 years ago at DPH, we had, LCR and whatnot, but there were things where there was, I think, a little bit more effort. And now in some cases, even you can go onto an app and access something. In terms of kind of an immediate uptick, I don't know that we have a specific root cause to share, but I will say that the Privacy Office is very actively, they've been sending out additional privacy pulses and trying to do targeted education with some of those groups where we've noticed that there's kind of been a spike and or that they're in a higher likelihood of potentially breaching information just due to the sheer records. Because as a staff nurse, I might get my assigned patients and I only look at those 4 records in a shift. But for somebody whose job is to interface with the public, where they're constantly coming and trying to find the right Ryan McDonald, that may be something that is more challenging.
Okay, so I think because we've kind of highlighted this one, that maybe in a quarter you could come back and whether it's gone up or not, but provide us some of the corrective actions you're taking yourself and whether you feel that these are effective because, as I said, privacy breaches are sort of in the public realm now, right? So to speak.
Absolutely.
Otherwise, I appreciate also that you're giving us the historical perspective that the number of fries outstanding are not unusual and something that your colleagues also are talking about within acute care hospitals, and that helps us since we've all, many of us, been monitoring our sister hospital and, and the problem with fries over there. So thank you very much. Are there any other comments? I can't see anybody's hand here, but I'd be happy.
Dr. Chow, I'd just like to say that this was really clearly presented, and I appreciate that greatly. And one other question on the privacy end. You mentioned apps. Do you find that those are creating or presenting challenges that were not present before, and that it has something to do with these breaches at times?
I would say that it will be on next month's report, but tomorrow we're about to report one where an app was involved of someone snooping. And I would say I think it's, on the one hand, I think it's an important tool that, right, the ability that I can walk up here and just pull up privacy breaches instead of having a stack of paper is a huge benefit to the world that we currently live in. At the same time, that added access to information does come with additional risks, and this is one of them.
Thank you.
Thank you. There are no other comments. We will then move on to our next item, please.
Sure. Thank you, Emma. Item 4 is the overview of ZSFG True North scorecard, and I will pull up the presentation. Just give me a second.
Good afternoon, Mr. Morwitz, Commissioner Green, Commissioner Christian, Commissioner Chow. I am delighted to be here today to talk about our Hoshin strategy. Just to remind us, this is a presentation we do for you quarterly to help you understand how we're doing on our strategic goals. And today is a really exciting time to be doing this because we kicked off really in earnest yesterday our Hoshin for the next year. So it's fresh in our minds, the deep thinking that we're doing, not just about where we are in these strategies and with this Hoshin, but how we can improve it and really change it up somewhat for the next year so that we are working as closely as we can on improving our patients' quality experience, our staff experience, all of the things that we want to impact here. And that's super exciting for me at this time because we have this newly reconstituted executive team that has all kinds of great new and fresh ideas about this and is working really well together. So I couldn't be more delighted about that. I did want to mention on our staff engagement strategy, we are in the process of reassigning a executive sponsor for this. We haven't yet defined our metric. So when we get to that part, we're really going to focus in still on the workplace violence piece of it and leave the rest of it to the next time when we'll have something new for you. I also wanted to mention the topic of data because Dr. Chow, I know you want to talk about it and it relates to this presentation. So, and we don't need to go into it in depth now, but what I wanted to point out is that when we get to the next item, which is the CEO report, we are in the process of changing our data, and the data that's there, we are trying to look more like what we present to you each quarter. So this is kind of where we are for the year, and we're hoping that our data that comes to you each month is more aligned with how we're working our Hoshin, in addition to presenting the volume information. So we will get back to that on the next item. I'm the executive sponsor for the equity KPI. This is on the very top, and this is the percent of departments driving equity as defined by the percent of departments who are presenting each month at PIPs who choose an active equity driver. And you can see that we are green here, which means that we're the strategies that we're using to encourage departments to do this and to coach and mentor them to do that is working. So we're going to continue doing what we're doing now and to continue to drive the percentage of departments even higher. And you can see from the data that we present later that in some months it's 100% of departments who are doing this, which is really nice to see.
Dr. Ehrlich, your slide
Yes.
actually is on the second page. Do you want to, bring the slide up that talks about, you're now talking about in terms of the CMS star rating?
Oh, I'm actually talking about departments driving equity. I'll come to the true. I'll come to the True North outcome metrics at the end of this presentation.
All right, I just didn't know what page we were on. Thank you.
Sorry, yes, I'm talking about, I'm looking directly at the True North scorecard, and I'm talking about the first row, which is our equity True North metric.
All right, got you.
And now I'm going to turn it over to Adrian, who will be talking about our patient safety strategic initiative.
Good afternoon, Commissioners. I apologize for not being in the room. I'm going to talk about our 3 patient safety metrics. Bundle compliance for severe sepsis, hospital-acquired pressure injuries or HAPIs, and falls with injury. We are still working really hard on sepsis to redesign some workflows in our electronic health record, and we've submitted an SBAR to our IT partners to really begin to accurately measure all of the cases that go through. So we continue to be red in that.
Adrian, I'm sorry to interrupt you. Could you speak a little louder? Would you mind?
Sure. Yeah, no, sure. Sorry about that. So our bundle compliance remains red for sepsis, but there's ongoing work in EPIC to redesign how we document the care that we deliver, because what we have discovered is that the gap isn't the care that's delivered, the gaps in the documentation are now how EPIC allows us to document. HAPI, hospital-acquired pressure injuries, and I'm delighted to say that we continue to be green and continue to see very few HAPIs, none in the ICU, and 1 case in the med-surg units in the last 12 to 18 months. So that's really a testament to the hard work that the staff in ICU and med-surg have done in conjunction with our harm task force. The last metric we have is falls. It continues to be red, and it continues to be an obstacle and a struggle for us. We have made some progress in some of our inpatient units using our lean tactics and using the huddle boards and rounding with intent to address that. And we continue to work on that and aspire to reach our goal.
Great, thanks, Adrian. Good afternoon, Commissioners. Gabe Ortiz, Chief Medical Officer, and I have the privilege of presenting our strategy titled Harmonizing and Synergizing Access and Flow to the ZSFG campus. This one will be fresh in your minds because our Chief Nursing Officer, who co-sponsors this with me, presented an overview of this strategy last month. While we are in the red for the 5 KPIs that we are targeting for access and flow, there are a lot of great countermeasures that are in the process, if not already deployed, to address these. And with your all's questions from last month, we are kind of thinking deeply about how we can continue to deepen our approaches to our 5 different KPIs. So to walk through them, our first 2 KPIs are focused in our emergency department. These are KPIs really meant to increase our ability to receive patients on our campus and not turn them away. So we aim to decrease ambulance diversion or time spent on ambulance diversion, as well as the percentage of patients who leave without being seen. As you can see, both of these metrics are relatively stable but not improving. And so ambulance diversion calendar year to date is at 45% and left without being seen at 6.8%. What we're doing to address these, we are actively engaging with the ED leadership team to hire up our ED nurse practitioners who are critical for the standard work we aspire to do in the triage and waiting room area to kind of care for patients when they're waiting, so we can start the care as soon as possible and not have them leave without being seen. We have deployed standard work for ambulance diversion, and the improved nurse staffing has actually allowed us to maintain a stable ambulance diversion rate despite demands being very, very high. And I think there's a theme across all of our care areas on the ZSFG campus that we're seeing more demand for care on our campus, rising demands compared to prior years. And then the ED is dependent on what happens kind of in the rest of the campus, particularly on the inpatient units. And so the throughput KPIs that you see here link back to the ED and allow us to get patients out of the ED and up onto our units. Our third KPI is increasing the percentage of cases that are add-on cases. This is critical not just for access and having patients receive the surgery that they need within our organization, but also critical because patients who are add-ons onto the OR, patients who are currently hospitalized and are waiting for time in the operating room to receive their care so they can actually discharge from the hospital. So this is a critical metric for decreasing length of stay. Our calendar year-to-date performance on this is 64%. That's kind of a little bit worse than it was in calendar year 23, where we are at 58% of these cases being completed. We aspire to be at 95%. A really critical countermeasure is going to be deployed on October 1st. So we are opening up the 9th operating room, so an OR expansion to increase capacity. And within that plan, there are specific OR block times dedicated to these patients who are waiting in the hospital for a surgical procedure. And we anticipate that that will decrease the length of stay and produce more hospital capacity for throughput. And this is in addition to what our perioperative team has already been doing in terms of creatively using any unused block times to bring patients who are waiting for operative procedures down to the OR. Our fourth KPI has to do with specialty care clinic access. So if our patients get good ambulatory care and good specialty care, they are more likely to stay out of the hospital. So this is critical for decreasing admissions, but also giving the patients the care that they require and they need and they deserve. The metric for this is third next available appointment being within 21 days for new referrals. You can see we're really close to target here. Calendar year to date, we're at 83%. That's a little bit below where we were in calendar year 23, where we were at 85% TNNA of less than 21 days. We aspire to be at 90% of all patients get referred as new patients to be able to be seen within 21 days. We have been working on decreasing out-of-network referrals. Those ticked up in the month of August. That's definitely contributing to kind of preserving clinic access for the patients in our network. I've been working on thinking about no-show rates so that we can use the time that we have to the best of our ability, and working with the San Francisco Health Plan on a grant to add night and weekend clinics to targeted specialty care areas to increase availability of clinics and bring TNA down for clinics that particularly have high waiting times. And so we have some good plans in place there for increasing access for our patients. And the final KPIs are lower level of care patient days. This is kind of we reflected on last month is quite high. It's at calendar year to date 2,030 days per month are kind of lower level of care patient days. And we aspire to be about half that. This is a really complicated metric. We have challenged our teams to think about what is within our control within the lower level of care problem, working on PDSAs to enhance or increase the alignment of our internal teams so that when we do have a disposition identified, we don't delay in getting patients out to that disposition. And then as 4A closes, kind of you saw the census dropping on in our skilled nursing facility. We're really partnering with Laguna Honda to try to get as many patients as are appropriate to Laguna Honda. And so we're actively partnering with them in terms of establishing referral workflows and identifying patients that are good candidates for receiving care over at Laguna, and thereby creating a new stream of disposition for our patients who are SNF eligible. And those are the 5 KPIs for our harmonizing and synergizing access and flow. I'll pause there and turn the floor over to Angela.
Hi, my name is Angelica Jernigan. I am the Chief Administrative Officer, and I'm here on behalf of myself and Adrian Smith, who are responsible for being the executive sponsors for our workplace violence prevention strategy. So since our last report 4 months ago, or a quarter ago, we've mostly stayed steady at 5 physical assaults with injury. However, in August, we did have a spike up to 10. Doing a deep dive into trying to figure out why that happened, we saw the spikes were really in psychiatry, which had 5, so in PES, and then in med-surg, which had 3. For med-surg, the 3 were actually all from one single patient. So there was just kind of an unfortunate incident with a repeat person who was misbehaving, I would say. In psychiatry, of the 5 events, 2 were by the same patient. However, they've come up with several countermeasures to kind of address some of the incidents that happened. So one countermeasure is that they're trained 2 additional new trainers to be able to work with staff in an additional manner and get them kind of up to speed on what they should be doing. They've also added monthly practice sessions to be able to kind of reiterate the training. So that I know, any type of training you get, you forget it after a while. And so adding the monthly practice sessions will kind of really re-emphasizes that lesson for our staff. And in addition, they are planning huddles at night, as we had some of the incidents take place on night shift. And so trying to use huddles to, again, re-emphasize the training, remind staff who might be working in an off shift of the correct way to kind of de-escalate situations. So on a good note, looking at September, we are actually back on track to go for our numbers to go back down, knock on wood, for the rest of this month that nothing else happens. So we're hoping that those interventions will help in the future. In a broader sense for our entire strategy, one success that we've really had this past month is related to training, where our emergency department had 100% of their staff trained at the end of August. Now, that's a moving target, because as soon as someone gets trained, you've been a year, you might not qualify again. But we're really excited they managed to reach that standpoint, because that's significant to get everybody trained. As a reminder, our CPI training covers a variety of topics, including nonverbal and verbal techniques to prevent escalating behavior, how to develop team interventions and strategies and techniques, and also it does touch on physical control and restraint positions as a last resort in these incidences. One challenge that we're kind of continuing, and that's kind of hard to quantify, I just wanted to bring up, is that we've received anecdotal evidence from staff that we need to do a better job of communicating our results. So what are we doing around workplace violence? We send out emails, and people get really busy. And so over the course of the next couple of months, we're going to be working with our assault governance team to really develop a PDSA and some strategies to make sure that we're closing the loop with staff, doing additional communication about the work that we're doing, and not just relying on just training for us to be able to talk about workplace violence, but try to take some of the other opportunities to really emphasize a culture of safety within the workplace. So that is our workplace violence update. So I will turn it over to Eric to talk about finance.
Good afternoon, Commissioners. Mark Morowitz, Eric Wood, Chief Financial Officer for ZSFG. Happy to be back again to present on our strategy. The title of our strategy is Revenue Cycle Optimization, and our target is to reduce the primary denials rate down to 15% by the end of calendar year 2024. Building on our presentation from last month, our team continues to make significant progress in identifying the contributors and reducing the denials rate by leveraging continuous PDSA to refine and improve our processes. In June, Denials Task Force, led by Rihanna Morgus and Marissa Foster, presented a comprehensive countermeasure summary to the executive team, which highlighted key drivers behind the June denials percentage spike that you see on the scorecard here. So the June denials rate increase was largely driven by several issues, including the transition to new payers with the BHS Go Live, which resulted in about 4% of the total denials rate that you see in June. Additionally, there were some payer system issues which played a role. Medi-Cal contributed another 4% to denials due to internal audits and claims reprocessing. Also, the introduction of billing observation services to the health plan contributed to the denials spike increases in June as well. Since then, our team has been actively working on implementing specific corrective actions to mitigate these issues. The team is holding problematic claims to identify and resolve these issues, and also collaborating with IT to implement payer logic updates in order to prevent these issues from reoccurring in the future. Lastly, the team will be working on implementing a real-time denials management system specifically to target medical necessity denials. In addition to addressing some of these more immediate issues, the team has been engaging in more deeper analysis to develop a more comprehensive strategy for revenue cycle optimization. I'm excited to share that we have a plan to expand both our strategic and operational metrics, which will allow us to better track and measure different points of the revenue cycle. And I believe it's going to provide better insights into denials management and allow us to be more proactive in really decision-making and helping us to sustain performance improvements in revenue cycle. I look forward to sharing these new metrics with the Commission at a later date once they're finalized. Lastly, I want to take this opportunity to celebrate the outstanding work the Denials Task Force has done, specifically Brianna Morgus and Marissa Foster for their dedication and really helping us understand the contributors to denials, and Chris Ross in the ZSFG KPO has really been instrumental in kind of driving these improvements and really helping to shape our strategy. And I'll stop there and on back to Susan. Thank you so much.
Hello again. Still Susan Ehrlich, CEO of ZSFG. So I'm going to bring us home by talking about our True North metrics. And these are on a separate page, as you pointed out, Dr. Chow, so they're bigger and we can see them easier. To remind us, the True North strategies are strategies that we expect to achieve within 3 to 5 years. And the trick of HOSHN especially is to make sure that the key strategic metrics that we choose, the ones that we just talked about, are ones that are likely to drive these True North metrics. So we want these True North metrics to be the most important things that we're working on over the long term, and we want our strategic initiatives to be driving these metrics. So a really good example of that relates to our star rating. And thankfully, our star rating, which is a 40-ish metric composite on which we're rated every year by the federal government. We are green, meaning that we have reached 2 stars, which is something that we did during the last year. As we analyzed where we had threats in portions of the star rating, we realized that we weren't performing very well in sepsis. So that is why sepsis now is part of our safety metric and something that we're very eager to move on. We will likely be seeing other metrics rise to the top as we see these threats when we dig down into the way the CMS star rating is constructed. The next 3 metrics have to do with engagement. The first 2 have to do with patient engagement and satisfaction, and the third has to do with staff engagement and satisfaction. These things are very related to one another, but let me talk about them on their own. The first one is likelihood to recommend hospital to family, to friends and family. This is measured through our HCAP survey, which is administered by mail, unfortunately, because we don't get a good return rate through our HCAP survey. And you can see here that we are in the red. We're slightly below overall where we want to be. Our target is 77%. We're at 75.9%. We've broken it down by race and ethnicity, but we don't color code those. And the reason for that is because we're not really directly driving these. We expect the work that we do in the strategic initiatives to have multiple effects on these. So because we're not driving them, we don't color code them individually. The second one is the likelihood to recommend provider's office to friends and family. So the first one is measuring satisfaction with inpatient care, and the second one is with outpatient care. Now this one we have a real-time survey for, so we have better participation and more likely to have an accurate representation of what we're actually doing. And there we're also behind 77.4% versus 80% at our target. We are, as you know, we're retooling our engagement strategy, so we hope to have metrics that really impact these in a positive way. The third one is our likelihood to recommend ZSFG as a workplace. And all we have here is baseline because we only administer this survey once every couple of years. The last time we did was in 23. We're about to, as a department, issue another one in 25. I think, my hope would be that at some point we can get to the point where we're doing pulse surveys, where we can track this more frequently than every 2 years. The last one is the general fund spend not to exceed our budgeted amount. This is our True North metric to measure our ability to be good financial stewards. And we have long thought, well, how can we be better financial stewards than to, really keep an eye on the general fund spending? There are some problems with the way this gets calculated, and I'm not sure, and we've had some discussions about whether or not this truly is the best long-term metric to measure our financial stewardship. So we're going to likely be looking at this again in our Hoshin process. But we are green on it now, meaning that we're not spending as much general fund as we were budgeted to spend this year. So that is our wrap up on the True North and all of our strategic initiatives for this quarter. I'm happy to answer any questions or offer up my colleagues to do so.
Thank you very much. Mark, do we have any public comment?
We do not have any public comment.
Okay, so this time we'll start with Commissioner Green.
Well, thank you I love these reports. They're so terrific. I have a simple question and then a add-on. Because in our place, is it 24 hours? How do you decide what an add-on is? Someone that comes in the trauma service or someone who knows they need a debridement? I mean, how do you count?
We have add-ons that are measured in certain amounts of time. This one is specifically 24 hours.
24 hours.
So we expect these are cases that are not scheduled and should be done within 24 hours.
And do we know how many of those are like acute, unpredictable trauma cases that come in, and how many of them are folks that you kind of know need a procedure and finally decide yes?
I could get those numbers. I don't have those numbers off the top of my head. There are things, a lot of these are like appendicitis or gallbladder surgeries that kind of are not emergent right now, and kind of teams are watching or treating with antibiotics and wanting to kind of remove the gallbladder or kind of perform that procedure to kind of get that done. There are sometimes patients that need to go back for repeat debridements or washouts, and sometimes kind of get bumped for the traumas that are coming through the ED or emergent kind of procedures that must happen more immediately. I can certainly get a breakdown of all the U24 kind of add-on cases that we try to schedule and kind of give you a flavor of what the breakdown is in terms of the indication for the procedure.
No, well, it's a big challenge in every institution. Where I work, they have livers, they have kidneys, they have all kinds of stuff, and it's just, and we don't even do trauma. And, I've waited 6 hours to get a 15-minute case on because it's so difficult, and you've got the staffing issues and the overtime issues. It's a big challenge.
Yeah.
But it sounds like that extra operating room, and it'll operate. What do you do at night? I mean, how many operating rooms do you actually keep open over the course of time?
Right now we have 8. On the weekends, I believe they have 2 or 3 on the weekends, and this will add a 9th room, kind of Monday through Friday, to increase the capacity for not just patients that are trying to be scheduled for elective procedures, but also all of the cases that are waiting in the hospital that currently, get bumped when an emergency comes in, which is appropriate.
So like as the day wears on, I know at our place they limit the number of ORs they keep open. They only staff for a certain number. And so, I mean, that obviously has implications in terms of people getting bumped and getting on the schedule at all. In terms of how that works, is there any, I mean, it's probably very difficult to see any trend lines where I mean, that's one of the big problems with the OR. There are certain things you just can't figure out, and among them are, who's going to have those needs, and is it cyclical? Can you make anything out of data where you might say, well, in the evening we don't keep all 8 ORs running, but maybe we should staff X number, and in the weekends as well. Is there any, as you evolve this, how are all those elements coming to play? Because you're looking at staff needing to come in and time and a half and all these other things if you have to open an OR that wasn't anticipated, but issues if you keep an OR open that lies fallow.
Yeah, the team, so we're the team and ourselves are going to be keeping really close tabs on this. You raise all great points. There are a lot of balance metrics or additional kind of returns on having this extra capacity. One thing that in Peri-Op Committee we discussed this month was also the amount of time that our surgeons are spending after hours on procedures that should be done during the daytime, things of that nature. So we'll be keeping an eye on a variety of different metrics because there'll be, the impact of this, we're anticipating there are going to be multiple positives in addition to kind of getting our patients kind of their procedures done in a timely way. And so all the things you mentioned are things that the team has discussed in terms of what is the real impact in all of the different ways, not just kind of the percentage of these cases that we're completing. So I'm really excited about this project, and kind of Dini Palaniappa and Patty Coggin, our MD lead and nursing director lead, have just been really thoughtful in engaging all of our surgeons and getting a lot of input on kind of the plan. So we can certainly come back and I'm excited to see how we can increase the percentage of patients who are in our hospital waiting for procedures, but also all of those other returns for kind of the rest of our patient population in addition.
Thank you. And also, were there any particular kinds of sepsis or services that had more issues with sepsis than others? I mean, is it mainly urosepsis? Is it wound? How does the sepsis break down in terms of areas that are...
So for the sepsis bundle work, I forget Adrian's online, but he can jump in too. But this is focused on patients entering our organization, mainly in the emergency department to start, and in kind of thinking through the scope of the project with the team. Our ED teams do an incredible job at treating sepsis. Our outcomes are actually quite good. It's the documentation parts that we often fall short on in terms of, saying that I drew the cultures before giving the antibiotics, how much fluids, and kind of the timing of those, the lactates, and kind of what we're building is a strategic plan to be able to make that documentation easier so that kind of in the fast-paced environment of the ED, we're actually getting credit, get the appropriate credit that we're due in terms of documenting the great sepsis care, being mindful of our screening processes and trying to be smart about how have we risk stratified this patient, and kind of is this patient truly on a sepsis pathway, or they really here with pancreatitis or some other clinical condition. And then the follow-through in terms of then the follow-up steps that are needed and having good reminders for the teams to kind of come back and in the appropriate time reassess volume resuscitation or kind of other parameters that are part of that bundle compliance. So a fair amount of the issue is the tools to make it easy to document what we're doing and kind of the great care that's happening. And then the hopes is that then we can spread that. So most of our sepsis patients come in through the ED. We get a lot of pneumonia with sepsis. You get a lot of UTIs with sepsis. Probably our top diagnosis is skin and soft tissue infection with sepsis. But kind of making sure that the tools are in place to be able to document the great care that's already happening, so we actually can prove that we're kind of following all the guidelines and delivering the care.
And there are order sets, I assume, for each one of these subsets. I mean, Epic has a lot of those.
It's like, yeah, it's order sets embedded inside of a care pathway. So we're leveraging that clinical decision support that Epic allows within these care pathways to help kind of guide the teams to document in a timely way the right things that they're doing, and also then the reminders for the follow-ups, and kind of having structured orders so that teams don't have to remember all the different things they have to order.
And then just an overarching question, you know, so many of these goals are so laudable, but some of them seem like stretch. And I'm wondering, I know you think about how to, you know, where to set the goals. I mean, you're so close in so many of them, but is there a strategy where certain ones you want to make easier to achieve and others you purposely make reach goals? Or when you look at it overall, how do you kind of strategize how many things you'll end up in the next quarter with reds versus greens? Is that anything that, you know, it's so nice to see green.
Yeah. Well, I'll comment, and I'll kind of turn it over to Susan to kind of comment even further. But I think the stretch goals are really critically important because it establishes and sets the culture for kind of what we want our teams to be thinking about. Even if we can't, let's say, drive down lower level of care to where we want to be, it's an important issue. We want to acknowledge that as an important issue. If we were to solve that issue, today we'd have another 60 hospital beds, for example. And so it's a quite meaningful issue. I think the process of HOSHN is that we identify these truly meaningful strategic initiatives that hold true over time as making an impact. And even if we don't get all the way there, the fact that we're trying, the fact that kind of bearing fruit from thinking about these problems are an OR expansion plan that kind of feeds back into, you know, some lower level care days just waiting for the operating room, for example, in addition to decreasing length of stay and helping our patients get through the system in terms of getting the care that they need efficiently. And so I think it's a great question. It's one that kind of our executive team is right now in the middle of, in terms of thinking about all of our drivers, the KPIs, how they feed into the True North metrics that Susan laid out. And even if they are stretch goals, I think the process of working through and trying to solve the issues is just as important as hitting the green.
Thank you. That is I really appreciate that understanding. That makes a lot of sense. Well, congratulations on the wonderful work.
That was perfect. I'll just say it's important to distinguish between targets and ultimate goals. So for example, workplace violence, right? Our goal is to have no assaults with injury. And we recognize that that's probably not realistic in the near term. So we're going to pick a target that seems aspirational but reachable. So I think that's what you'll see with a lot of our targets, that we try to put something that is, you know, aspirational. And you know that from looking at our scorecards over time, there's a lot of red, which to me shows that we're doing a good job of setting the targets that way.
Great. Thank you. That I always like to hear that and understand it better. And I love what you said about, you know, the goals versus the targets. That makes a tremendous amount of sense. Thank you.
Sure.
Thank you. Commissioner Christian?
Thank you. And Dr. Ehrlich, I'll stay with you and the physical assaults with injury. And I believe Ms. Jernigan, if I understood correctly, indicated that two separate individuals are responsible for the total number?
Not the total number. So two individuals were responsible for half of them. So for five.
For five of them.
For five of the
Okay. And so you mentioned a number of things, and I'd just like to hear a little more about how you're conceptualizing this, how you're thinking about it, and how you're organizing it. So you talked about, for instance, huddles. If you could just remind me what you all mean by huddles, and is it getting together at the beginning of a shift and checking in at the middle and at the end? Is that what a huddle is?
So it's getting together at the beginning of the shift, kind of like during shift change one to kind of, some of our departments have, very advanced huddle boards that they kind of go and are able to kind of share notices of what's going on within the unit, what people need to know for the night, and just kind of making sure that people, like the information is kind of spread from like one shift to the next. So it's kind of at that moment, taking that opportunity where people are already coming together to talk about what's going on the unit for that shift, to also provide some education and touch points about how we can do better to prevent workplace violence.
Mm-hmm. Thank you. So is the idea or the hope, or at least the aspiration, that most of this is within the control of the people who are working, understanding that there will be individuals who come in who will be in distress, who will be decompensated, and there are ways to approach and interact with people who are in those states? And is the idea that that will happen, and there are ways that we know of to interact that will prohibit or decrease the any harm that is done to anyone?
Yeah, so one of the reasons, so I think that's a really good kind of explanation of what our thought process is that we, kind of getting back to the theme of we want to make sure that we can control what we can control. We want to make sure that we're, not unintentionally escalating situations or triggering our patients. So if we can provide training to de-escalate patients, to help bring them down, to calm down the situation, that's something that we can control. In addition, the training acknowledges that sometimes we just, some people are just going to be not in a mind space or not in a physical place to follow the rules or to not resort to kind of escalation. And so how do we mitigate harm? And so that's one of the reasons why our metric that we're following is physical violence with injury, because we also report on, people getting hurt, but, sometimes, well, we have reports on like someone getting slapped, right? But they didn't actually get hurt. But we want to make sure that we don't actually, our staff members aren't actually harmed in case these events do happen.
Mm-hmm. Yeah, because that's a lot of harm to take place in a month. 10 individuals having an injury, and I'm sure that this isn't what's happening, but I just no one would want the while it's necessary for everybody to check in about what went on and how it was engaged with, and could we have done better, or did we do all that we could do, that there isn't necessarily a go-to of that this is the staff's deficit that led to this jump in numbers. And something did, but not the explanation, the ready explanation not being that it's the staff's fault.
Yeah, completely agree. So one of the things that our directors, especially in our assault governance meeting, and then our Adrian staff with risk, is really careful to do, is to make sure people understand this isn't meant to be punitive. This is all kind of a learning situation, and to understand, again, we are just trying to focus on what people can control, because even in some of the incidents that we happened, some of it, some things we can always do better, we can always do improve, but sometimes, there was one incident just involved someone's support animal, so then that resulted in injury to the nurse. They couldn't control that. And so,
Can't de-escalate the dog.
Yeah, exactly. So trying to be, I think, in our training, trying to be sensitive to our staff, because again, one, we want them to report, and we don't want to make them scared to report because they're worried that something's going to, like, that they'll be retaliated against for reporting. But we also just kind of acknowledge that, people are people, and we try to work with them the best that we can.
Yeah, the work is hard anyway, but the situation is just inherently difficult. I mean, think about, getting up to, going to work on Monday morning. It's like never a pleasant experience for me. And I have to, internally get myself into just a better place to deal with what is in front of me. And so I'm imagining that people, is there any focus on that kind of like preparation of yourself as you come onto the shift in the huddle or before the huddle or anything like that?
So I would have to follow up to see like how often that's happening in the huddles. I will tell you that part of the CPI training is also just focused on just bringing like a helpful attitude and professionalism when you're interacting with patients, so that people, it's hard to leave your everything at home, right? We're all people and we are bringing everything with us. But the concept is, at least in that one interaction, can you take a deep breath? How do you center yourself and kind of go into the interaction with the patient in a better mindset?
Yeah, it's good to, I mean, I certainly expect this, and it's good to know that the humanity of the staff is, front and center in this process as well, and acknowledging that and making sure that they acknowledge that in themselves as well before they start the difficult work of their shift. Thank you.
Yeah.
Thank you, and I want to thank all the presenters. It was a very helpful going through the third quarter of your of the True North scorecard, and some of the questions I had were already answered. So it's great to have my colleagues be able to answer those, and I won't have any at this point, and we can go on to our next item.
Great, thank you, everyone. Item 5 is the CEO report, emergency department newsletter, and BERT newsletter.
Good afternoon again, commissioners. Susan Ehrlich. I want to just give you an overview of what you have, because I realize that what you're getting now for the CEO report might be a little confusing. But first we have the narrative report, and we have the data that we have provided to you since time immemorial. We have the new data that is more reflective of the strategic initiatives we have. And then we have the emergency department and BERT. We are still in the process of coming up with one single data report. It's actually been a great opportunity for us to validate the data and make sure that we really know that the data we're reporting to you is accurate. And what I can say to you with confidence is that the new data that you're getting will definitely be part of what you get, and you will also get some of the volume metrics, like number of patients coming to the emergency department, number of people being hospitalized. We won't let those go. We just don't want to duplicate anything. So that's the data talk just to start. I will go through the narrative part of this before we dive even deeper into data. So first of all, I'm really delighted to report that we had the first known milk drive in San Francisco on our campus. It was incredible to be there and just see the energy and how we engaged folks. And then we collected a remarkable 3,135 ounces of milk during that drive, which is incredible. And that is really an amazing way that we can support, development of babies and help families in the Bay Area and our patient population especially. So that was fun, and we were already talking about how to have another one. In a different realm, in care experience, we have some examples of how much work we're doing to address substance use disorder on our campus. As you well know, this is the DPH's #1 priority, and I know that there's a lot of focus on people on the streets, but there actually is a lot of work that we do with patients in the hospital and also patients who are coming for outpatient care. And I'll just highlight some of these. So first of all, our OTOP program, Ward 93, This is our methadone program, which has been in existence on our campus for more than 50 years. Started during, right around the time of the Vietnam War, and has been setting standards for opiate use therapy for all of that time. There has been, we just heard from Hillary that there's been a 35% increase in access to methadone treatment slots since last year, and most of it is coming from OTOP. Funded, of course, through the settlement money, but nonetheless, we have been doing that. In addition, we have the Bridge Clinic that provides specialty substance use disorder treatment. It's a remarkable resource. We are also expanding this clinic significantly in Building 80 so that we can meet the demand of patients who are coming in for that. And Bridge is addressing opiate use disorder, but also alcohol use disorder and any other substance use disorder that our patients come in with. Team Lily we've talked about, which is it's a nice team-based model for women who, for people who are expecting babies and who are unhoused and have substance use disorder. So that's a very challenging population. We have really good experience now with buprenorphine prescribing in the ED. And then, of course, our addiction care team, which is our remarkable inpatient consultation service that recently has partnered with our Burst Center and trained 6 nurses in addiction medicine. So just a lot of work on campus, really exciting to see us evolving in the way that we meet our patients' needs in this area. Let's see, the next thing I wanted to highlight is our new leaders. I think I mentioned Angelica Almeida, who comes to us from Behavioral Health Services. She is our new Chief Integrative Officer. She's getting off to a very strong start. Our new permanent Director of Social Services, Michelle Lee, who's been with us for a while but is now permanent in this role. And then the last thing in the narrative I wanted to point out is how is our experience with faculty experience at ZSFG. And the thing that is so delightful about these data is that these are data that UCSF administers to its faculty in all of its sites. So Parnassus, Mission Bay, Mount Zion, the VA, and ZSFG, of course. And what we noticed from that survey is that not only are our burnout rates at ZSFG improving year over year, but our rates are better than any other UCSF site. I think the VA is comparable, but all of the rest of them, we are better. And so you might ask, well, why is that? And I think our best hypothesis is, number one, our mission, and the fact that we are all united in caring for a patient population that is truly needy and that we are really well poised and specialized to serve. And the second is, I think, our physician group and our hospital are all united in the same goal. You know, we have one physician group, not many. We are all united to take care of the same population in the community. And I think that really helps our faculty just feel good about the work that they do every day. Not to say that we don't have room for improvement, but it's a really nice validation that the work we're doing on our campus is supporting our faculty. So I'll stop there and go on to the data unless you have questions about any of this.
Oh, Commissioner Chow, you're muted.
Just wanted to know, commissioners, at this point have any questions, or shall we just move on to data and then we can ask the questions?
I have one comment I'd like to add, which is it's wonderful that you listed the mission and the hospital and the faculty and staff working in one direction. But I think it's everyone in this room. I think it's the leadership. You guys are amazing. And I think you all need to pat yourselves on the back. I mean, even as you've gone through the changes, I mean, I've been doing this with you guys for 6 years, and I come away just constantly inspired and impressed by everything I see in this room every time I come here. So please add that to your list. That was the one thing I had highlighted on the report, actually, the burnout part. I thought that was absolutely terrific.
Well, that's very hard for a humble person, but thank you very much for your support and your recognition.
And
Thank
I would
you.
echo that. I would echo that.
Thank you.
Okay. I think the leadership that you're bringing in too, as we go along, and as we lose good leaders, we also seem to be picking up people that you have chosen who are then moving to the next level. So it's just been amazing over these years to see the way that, especially that Dr. Ehrlich's administration has been able to move the needle, I think, at general. So thank you very much. And let's go on to the data.
Thank you, Dr. Chow. Yes, okay, so starting with the emergency department, we're busy. You can see that our month-to-date daily volume is higher than the prior fiscal year baseline. We just have a lot of people coming in. We are definitely the busiest department in emergency department in the city. And as we do better with ambulance diversion, these numbers are going to continue to go up. And I will note, just to say, August, September, October a little bit, these are typically the least busy times of the year. So it only goes up from here. But, you know, when you look at the volumes over time, that's very notable. Admissions from the ED is relatively stable. The next two charts I always like to talk about. So leave without being seen and leave without being triaged, as you know, is one of our strategic metrics that we're working on. This chart, I think, is a great representation of when you have a really hard problem to solve and you keep coming back at it in different ways. And this team in the emergency department has really done very resilient, very creative, and has really done a remarkable job to try to see, you know, how they can improve. So you can see we were way high, you know, back in 2022, came down, bumped back up again, you know, looked at it again. We had an increase again, and now we're coming back down. Month to date, I looked yesterday, was 5.9%. Gabe mentioned this, but I'll just reinforce that what we really see as the best countermeasure we have right now is filling our nurse practitioner vacancies, because we've had really pretty significant problems with vacancies, leaves, and just really not having the bench that we need to address this problem. So we're feeling good about that because we're in the process of hiring those NPs and getting them onboarded. So over the next few months, we should see this continue to come down. Same with ambulance diversion. Month to date here, 43.5%. The thing that has made the biggest difference to allow us to keep it down around 40% is staffing. You know, I go to the emergency department huddle several times a week, and the big theme recently is we have never been as well staffed as we are right now. And the staffing is what is enabling us to manage the diversion. At the same time, we have, you know, pretty high boarding still in the ED. So the staffing has made a huge difference, and I really want to thank our HR partners for helping us do that. And I know they'll talk about that as soon as I'm done. Let's see, just to continue on, most of these haven't really changed very much. I do want to say on page 14, the average daily admissions to inpatient psychiatry from PES, these are low. This is a really good indication of the gridlock that we're experiencing on our inpatient psychiatric unit. We talk a lot about med-surg, but we really are experiencing it here as well. The other ones there's not a lot to talk about. I do, in terms of volume, you can see that our medical surgical volume remains quite high. And again, this is the time of year when this census should be low, and it's not. And you can see that it actually exceeds the capacity of our physical med-surg beds because we have people boarding in the emergency department, in the PACU, in the ICU. It's just, we have a lot of folks. Intensive care, though, you can see the seasonal changes. So this is low, and we expect it to be low, and you can be assured that as the months go on, it will peak back up around the peaks that you can see here on this graph. Maternal and child census, we had 1,200 births last year, which is a great thing for us. We went down as low as 900, I think, like right around the time the pandemic was starting. So this is a great thing. We have the capacity to take care of this volume, and so we want to make sure we keep it there. 4A, you can see the precipitous decline. As you know, our plan is to close the unit. I think today we had one patient on the unit with one bed hold, and so we're on track to close by the end of the month. And then we can get the work done, hopefully, as quickly as possible. One thing that we are doing to try to mitigate this and make the whole circumstance a big opportunity is that we're in the process of moving the 4A staff to H58, which is our, it used to be our overflow unit, now it's, our main surge unit. And so we're gonna basically have those staff there and try to cohort some of our lower level patients on that unit and see if we can use that as an opportunity to help them get mobilized and move more quickly. So the manager there, or the nursing director, is working on standards for which patients go there and how we can use that as an opportunity, but more to come on that. And then the lower level graphs really haven't changed very much. And we'll address that more, in our strategic work. We talked a lot about workplace violence activity, so I won't go into that in detail. So I'll stop there on the typical data you see, and I won't actually go into the other data in detail since we spent so much time on it for the True North scorecard unless you have any questions about it. I hope that we will have a consolidated data scorecard for you within either the next month or the month after that. That's our goal.
Commissioners, any questions? And I think Commissioner Chow wanted to actually speak about this, but it seems he stepped away for a moment. So I guess we can take a pause until he gets back, unless you all.
This is great. I love the pictures of everyone. I love this emergency room report. Mm-hmm. Everyone looks so young to me.
Yeah, that's because they are.
But they're experienced trauma people, and I'm like.
Yeah, these reports are really nice. And a good example of an intervention to improve staff engagement and wellness.
Commissioner Chow, I believe Dr. Ehrlich is done with the presentation, and this is the time to maybe talk about the data.
She also did the ones on the scorecard, or she just finished this part of it? I'm sorry, I had to leave for a semi-emergency.
Oh, I hope everything is okay, Dr. Chow. I went through the data, the usual data report that we have. I am deferring any detailed discussion of the new scorecard because we just had a lot of discussion about these metrics in our True North scorecard. And then what I said was that we hope to have a newly validated and consolidated single scorecard for you either next month or the month after.
Okay, right. I thought that what you're saying really anticipates what I was hoping that we would hear from staff and yourself in terms of the use of this data. Of course, for example, some of it is duplicative, right? Left without being seen, and is of a deeper dive into that. So probably would be looking at maybe using something like that, but it's quite useful to be able to look at your sepsis bundle and be able to understand the ups and downs and your happy scores and so forth. So I would, want us to see if we would then look forward to how you would consolidate that. On the med surge left without being seen curve, part of the problem with data, and it's not your problem, we see it almost everywhere that is trying to put together data, is that when you come to part of a month, that part of the month always looks lower than the rest of the month because it's not complete. And and so it looks like in your lower level of care, I mean, in terms of your data there, it's I would say a little concerning or misleading, right? Because it looks like the September suddenly has a big drop, but we're not done with September. But so I don't, I don't have a real answer to how we take care of that, except to try to remember that it's only a partial month. But I
Right.
so my other comment, which I wanted to make, was that I thought your med surge occupancy was very busy, and I don't know that it assists us as much as your cleaner volume data that you have in the preceding presentations. But I suppose it looks at, fluctuations per day of our occupancy rate, but it's to me less clean in terms of looking at a trend. And perhaps this might be one that is just maybe overloaded with data compared to what you're using right now in terms of occupancy. But those are just my personal comments, and I didn't know if we could be helpful with each of our commissioners, perhaps giving a flavor of what they're seeing right now as you're looking at trying to consolidate this all into one data package in the next month or two. So Commissioner Christian, any thoughts?
Well, I really liked the drivers and this graph. It's wonderful. And I think for me, easier to see trends. With this new one, I'd love to just have a little more time to look at it. I do kind of like seeing the number of borders because it's at the first of every month, you're getting a summary of the month. Actually, the graphs, these colored graphs, the tall ones here, are very similar to what we get on vacancy rates and similar to what we get in that area from Laguna Honda. So I probably want to just think about it a little more.
Great.
Yeah, we want to give you data that, well, first of all, for the strategic metrics, we didn't want you to have to wait a quarter to see what's happening. And then with the volume metrics, we want to show you the data in the clearest way that we can, and also not duplicate anything.
Right, Commissioner Christian, any thoughts?
I have the same response that my colleague did, and I would like to be able to kind of get used to it a little more, but finding it useful, but orienting myself.
Yeah, sorry to be confusing. We love data, so maybe we overloaded a little bit, but we are now in the process of cleaning it up, so we will have something that makes more sense.
Well, it's really important to have data for us to be able to make any determination. So I don't think the staff should be faulted for providing sometimes more data. The question is, how can it be more cleanly or more clearly presented that would allow us to look at trends and have discussions and try to make recommendations off of it. So the amount of data that you've been able to draw out has been amazing compared to where we were a few months ago even. And I know that in the past you've said, I'm not sure I can rely on the data. So now it looks like in your statement today, you can rely on the data. And the question is, how is it best to present so that we can make best use of the data for our purposes. So thank you very much, and we'll look forward to your coming iterations and thoughts, and appreciate that we can have this as a iterative process as we
Great.
move forward. Does that make some sense?
Yes, thank you, Dr. Chow.
Okay, thank you. All right, so we'll go on to our next item, please.
Thank you, Dr. Ehrlich. Item 6 is a hiring and vacancy report.
Good afternoon, Commissioners. Emma Perez, Clinical Hiring Team Supervisor with the Human Resources Report. Before I get started, I just wanted to say we're very excited that we have a new ZSFG HR Operations Manager, so she will be presented next month, and we're just very excited that we finally have someone on board, and you'll be able to meet her next month. Okay, so our total hospital vacancies slightly decreased, still 7%, right, 7.69% compared to 7.93% in July. We have hired 30 employees in the month of August in various classifications and had 8 separations during that period of time, one of which was a retirement. Our RN vacancy rate has remained the same at 6%. We continue to hire permanent nurses. 30 were hired in August at CSFG. Those included reassignments. We also hired 9 per diem nurses to fill gaps. We held the RN hiring event on the 14th of September, and it was a very successful event from everything that we've heard, both from hiring managers, candidates, nursing leadership. It was a true partnership with HR and had great representation from all the leadership at Zuckerberg, and as well as other locations. We had nursing directors from Laguna Honda, from Jail Health. So just about everyone was there to be able to meet and greet the candidates that came through and devoted their time to the hiring event. Saw lots of smiles from both candidates and hiring managers. We had a good turnout, and we'll be able to present more data probably next month on what resulted from that hiring event. But just overall, everyone felt like this hiring event really accomplished or met the target, which was really to bring people in so that we could then interview them and then make selections. So I think overall we're definitely headed in that direction. For the hiring event, we also launched our virtual interviews using our Smart Recruiters application, which was good learnings, but also just excited that we're able to start using that system as our system of record to document all selections. We continue to meet with our hospital executive team, program managers, everyone to really look at, still how to improve processes. We're doing okay with our hiring vacancy rate, but we obviously want to continue and make sure that we're filling all vacancies to get it down as low as possible. So for emergency care, we have 6 FTE vacancies. There's 4 selections made, and we have hires starting September 28th and October 12th. Critical care has 9.4 FTE vacancies. They've made 3 selections with target start work dates September 28th and October 12th. Medical surgical has 21.4 FTE, made 4 selections, again, hires in September and October. And our OR unit has 1 vacancy, and they're making selections. We still have a training program targeted for October to bring in, I believe, at least 6 trainees. And then we've also done non-RN hiring, so we hired an 0931 Manager 3 for Director of Social Services, Chief Nursing Officer 1165, 2 hospital eligibility workers, a nurse manager, and a central processing distribution technician, just as some of our highlights. I know that last time we met, there was a question about the 2310 surgical procedure technicians. I'm happy to report that we're making some progress in that direction in terms of hiring them in the OR. We have a list available, and hiring managers have conducted their interviews. Unfortunately, some of the candidates were not as responsive as we had wanted them to be, so we are following up with candidates just to make sure that we're continuing on in the process of filling those vacancies, and so we're working on that right now. But I wanted to see if there were any questions related to the hiring report.
Well, I want to thank you for having made the presentations over this hiatus of a director for Zuckerberg here, and thank you very much for the excellence in bringing to us the vacancy reports. Commissioners, questions of Ms. Perez?
Yeah, I do have one, and it stems from what was just being said about the nurse practitioners in the emergency room. On this last page, the 2328 and 2218, when we review privileges, I always see how many incredible privileges APCs have at the county, and I always try to put that in the context of how you decide to allocate positions, because I know obviously in privileges you have to put it all down, but sometimes, well, you don't know in a given specialty, like neurology being a great example. There's so many procedures that they can do. There's some of them very interventional, but you don't know the percentage of people in the department that are actually doing that as an APC compared to a resident or compared to faculty. So looking at this nurse practitioner, that there's 8.7 FTE vacancies. Are they mostly the emergency room? And then what about the PAs and how they're utilized, for example, in surgical assists? Are they utilized, or are there enough house staff that they actually do the surgical assists? In other words, I'm just curious to know where the, beyond the overall numbers, and it's not many, but beyond the overall numbers of vacancies, whether there's certain departments that have particular pain points for those APCs.
Yeah, so for the nurse practitioners, the majority are in the emergency room right now. 6 of them are, and I'm happy to report that they've actually made selections, so they're going to hire these 6 right now. They are working on hiring 2 additional nurse practitioners, for 1 in nursing administration and then 2 in, I'm sorry, so that's 3, 2 in the trauma program. So from my understanding, that's the majority of the places where the nurse practitioners are used. The physician assistants are primarily used in KSARC, and let me see if I can remember what it stands for. I know it's part of the Rape Treatment Center, so they deal with, with physician assistants, but it's really a matter of the hiring manager determining which job class they would like to use, because in many instances they can be used interchangeably, but it just depends on the hiring manager and what their needs are at that time to be able to fill those vacancies.
Thank you.
Yeah.
Thank you. Commissioner Christian, any comments or?
Thank you. Just a question. Thank you for the presentation and the amazing progress that you continue to make at every presentation that you give to us. So thank you very much. I just wondered if you could educate me a little bit regarding the job descriptions somewhat, but the work that the people like the behavioral health clinicians do with 16.1 utilized and 3.4, which is pretty low for what we're here, which we normally hear about, or at least I normally hear about the lack of filled positions in some of these very critical positions that we have in behavioral health. Or the health worker too, by contrast, 11.5 vacancies. Is there anything that you can usefully say at this point about the difficulty in hiring some of those spots?
I know historically, so my team doesn't hire the behavioral health clinicians, so I can't speak directly to the actual challenges, but I can definitely bring that back. I know historically they've had issues just recruiting candidates who have already completed their with their certifications and have completed the programs or their credentials. So my understanding is that and I'm trying to think back because it's been a while, they created a program that allows them to be able to be brought on and while they're trying to gain their credentials, so that at the time that they have their credentials, they can be, placed in those actual job classes. I don't have numbers, so I don't know, how successful that's been, but I know that they're definitely working on trying to, expand the pipelines to bring in candidates for those behavioral health positions. They also have a dedicated recruitment event for behavioral health clinicians. So I'll have to follow up because I don't have detailed information on those roles, but I know they're working on them.
Thank you. To the extent that it's easily done to give some presentation in the future about your strategies for these, extraordinarily necessary and critical, this work that is not being filled, and we're filling that impact in the city so much, and in the treatment courts especially as well, because we have so much staff, the overwhelming majority of staff coming from the department, in this being the foundation of this critical work. So it would be useful and interesting to me to understand what your strategies are, because you've created these very targeted strategies for other areas and have been so successful. And I know that the challenges are immense and completely out of your control, but it would be interesting to know what you can tell us.
Absolutely. Thank you.
Thank you.
I had a question with the wonderful graphs that you actually have concerning the vacancy rates for the different departments. That under Med-Surg, it looks like in July and August, you've had a challenge, but with increasing numbers that you were to recruit. Is that part of the new cohort that's supposed to be added to the hospital, or does this represent some sort of further, numbers of people who are leaving, or a combination? But I'm looking at the 2 months, July, August, on the graph that shows that all of a sudden we have more slots and, a larger number of vacancies.
Yeah, so that's primarily attributed to the fact that we got new positions in the budget, and so a lot of those positions were allotted to Med-Surg. So they're trying to fill these new positions. So that's why you'll see an increased vacancy rate for those months, is because we got these new positions that we're now hoping to fill primarily through the hiring event, but it could be, existing positions plus the additional Med-Surg positions that they received.
Well, I want to compliment you all too in terms of the graphs that we've been seeing here, because it certainly shows that in 2023, we can see all the gray areas, the vacancies, and how well we really are doing compared, not just compared to that, but how well we actually are really doing in filling the needed positions. And nice that we've had others allocated to Med-Surg, and we'll look forward to your filling those vacancies also. So thank you very much.
Thank you.
So we go on to our next item, please.
Yes, great. Item 7 is the medical staff report.
Good afternoon, Commissioners. Gabe Ortiz, Chief Medical Officer. I'll be presenting for Mary this month. And so before I jump into the med staff report, circling back to your question, President Green, about the add-on cases. So our ACMO and peri-op was able to give me a list. So it's mainly abdominal washouts, laparoscopic cholecystectomies, INDs, and kind of less emergent bony fracture repairs that kind of are the main reasons for those add-on cases that kind of get bumped for more emergency cases.
Thank you. Thank you.
So jumping into our med staff report, we had the real pleasure of hearing our laboratory medicine service report in September. Dr. Barb Haller presented. And I think the mission and kind of scope that she laid out really was nicely reflected throughout all the sections of this report. Really, they aim to provide accurate, timely, efficient, cost-effective, and high-quality lab services. And this department is such a critical department for the organization. Coming out of the pandemic, they are essential to so many workflows now across our organization for keeping patients and staff safe. So it was really great to reflect on all that's happening in this department. They have footprints throughout the campus, including in the Building 5, where they currently reside and where there's a lot of construction and seismic upgrade, which they mentioned in their report, to Building 25, where the blood bank is located and the point of care offices, to Building 100, where they house their lab info system, toxicology, serology, and lab support services. So really a broad footprint. They support over 500 different unique tests and transfusion services on top of that, and just have a huge kind of operation. Over 2 million tests since 2022 have been, billable tests have been completed, and kind of highlighting their cost effectiveness and kind of stewardship. They've managed to actually increase revenue while keeping costs flat and expanding the services that they've delivered over the last several years. So just an impressive group that we rely so heavily upon to deliver our clinical care. In addition to supporting all the clinical mission, they have a strong educational footprint, lots of trainees that rotate through, and lab scientists. They have a really strong culture, performance improvement, and patient safety. Just one example that stood out, kind of they analyzed HSV and VZV PCR tests that used to be send-outs. And after doing a really nice analysis, they saw that it would be more cost-effective and more patient-centered because of the better turnaround times to do it in-house. And they've had thousands of dollars of cost savings as a result, in addition to much more rapid turnaround times, as one of their performance improvement projects that Dr. Haller highlighted, which is just really great to see how they've been so thoughtful in their improvement strategy. They support research missions. They've been helping to analyze the impact of high sensitivity troponin assays on changes or impacts on clinical care, and are looking to add Chagas disease testing in the coming years. And in terms of their financial standing, I mentioned their revenue has been steadily going up while kind of maintaining a flat cost curve because of their mindfulness in smart expansion. So to summarize, just a very strong team. It was really kind of great to hear how this important team has been approaching their kind of growth. Their challenges are they have some key vacancies that they're looking to fill. They are moving into Epic in the next year, so that's a huge project for them. They're moving on to the Beaker platform within our electronic health record. They're also bringing in a SoftBank blood bank application to support transfusion services, and are undergoing a lot of construction. They're bringing in an automated core line in addition to all the seismic upgrades that are happening in Building 5. So it's a highly dynamic time for our clinical lab, and they've been managing to move all of their projects forward in addition to supporting the core mission. So just a really impressive report. In terms of the rules and regs, there were no significant changes. The minor changes were submitted for your review and approval with those tracked, really just minor edits to the prior year's rules and regs. And I'll pause there for questions or comments.
No public comment.
Thank you, commissioners. Any comments on this wonderful presentation?
I guess I have one. I mean, this is an incredible department. I was looking at this slide with all the things they do and then the numbers of individuals involved. Clinical lab is amazing. And I also am so impressed by the presentations. the photos, and I mean, it really brings the service to life. But, you know, within this is the spirit of a department that's working together. You can really see it with the photos, with the way this is put together. But, and each one of these seems to get better and better, and the graphics and everything else. But it's just a remarkable department, and I think I can speak for all of us that, you know, please extend to Dr. Haller our congratulations and awe at the way they're able to do this work. You know, I'm one person, and the number of lab tests I get per day in Epic and in the hospital is monumental, and then multiply that over an entire patient population, especially as complex as you have at the county, and their work really deserves accolades and is remarkable.
They are an incredible team. Thank you for those comments. You know, they support not just our campus, they support the acute medical unit at Laguna. They do testing for around the city. They support research missions. And just to highlight the real depth to the quality of the care that this team delivers, they had a stellar glowing review during the Joint Commission visit. I think it was, they mentioned it here, 7 findings out of all of the lab standards, kind of 99% in compliance for really a complex clinical operation. So they were really lauded for the great work that they do. And that's kind of highly representative, kind of, the pictures do speak 1,000 words, and there's proof of the pudding in terms of how they deliver those services. So it's really great.
That's wonderful.
Very impressive.
I'm wondering, you're saying that they're looking at adding a test for Chagas disease, but do we see a lot of Chagas disease here?
We don't see a lot, but when we do need to rule out, particularly for kind of cardiomyopathies or patients who are foreign-born or kind of exposed during foreign travel, and we want to make sure it's a really important kind of decision point to kind of rule that out. And so it's an important test and can take quite a while and can slow down particularly cardiac workups for kind of new heart failure or for evaluations for, you know, eligibility for transplantation, et cetera. And so I think it's a high impact test that kind of, because of that long turnaround time, can sometimes delay care progression. And so for our patient population, it kind of would be a meaningful test to be able to have on campus.
Sure. No, thank you. Learn something else about our population. Wonderful. Shall we go on to the service changes?
Yes, so very minimal service changes. They basically edited the table of contents, updated the unusual occurrence platform, which we use for reporting safety events, to the SAFE platform, updated the appendix, and changed UCSF Associates Dean to UCSF Vice Dean to be more accurate in terms of that label, Division Chief to Division Director, et cetera. Some leadership just titles to kind of clarify the roles as to who they were referring to within their rules and regs. And they did some formatting within the privileges, but no changes to the content. And so overall, kind of minor changes to the lab medicine rules and regs.
Thank you. Commissioners, questions on the rules and regs, or else a motion to accept? To recommend.
Move to accept the rules and regs.
I second.
And there's no public comment, so I will do a roll call vote. Commissioner Chow, how do you vote?
Yes.
Commissioner Green?
Yes.
Commissioner Christian?
Yes.
All right, these will be put on the consent calendar for the meeting at the full commission next week.
Thank you so much.
Thank you.
So we can move on to the next item, which is other business. There's no public comment, but any commissioner? Hearing none, we can move on to item 9, public comment. There's no public comment. There's no public in the room, and no one received permission to participate remotely. So we can move on to consideration for closed session.
Motion for closed session is in order.
So moved.
Second.
There's no public to make comments, so I'll do a roll call vote. Commissioner Christian?
Yes.
Commissioner Green?
Yes.
Commissioner Chow?
Yes.
All right, please give me 30 seconds to take us over. Thank you for closing the door. Commissioner Green?
Yes.
Commissioner Christian?
Yes.
Great. And then please have a consideration for a motion to adjourn.
So moved.
Second.
All right, Commissioner Chow, how do you vote?
Yes.
Commissioner Green?
Yes.
And Commissioner Christian?
Yes.
Thank you all so much. I'm going to take a second to close this out, so please know that we're still on the record. Thank you, everybody who attended and helped.